All right. The second part of this will be respiratory pathology. So, especially with COVID-19, we're probably looking at a lot of issues with the respiratory pathology. So, let's look at that. There's restrictive disorders that stiffen the lungs and reduce compliance, ease of inflammation. So, for example, fibrosis from tuberculosis. You get scarring in the lungs from that. Now, you have obstructive disorders that narrow the airways and interfere with airflow. So expiration requires more, so they can breathe in, but they can't breathe out. So some of those would be chronic obstructive pulmonary disorders such as COPD, includes bronchitis, bronchial inflammation and recurrent infections, emphysema. Asthma involves intense bronchoconstriction and airway inflammation. So that's obstructive. Restrictive would be tuberculosis. So make sure you know the difference between restrictive and obstructive. All right. So COPD, again, that's obstructive, exemplified by chronic emphysema and chronic bronchitis. So it's a conglomerate, okay, of these two. Key features: irreversible. Remember, irreversible decrease in ability to force air out of the lungs. So once the damage is done from COPD, you cannot go back. That's smoking, basically. Now, there are some rumors that you can undo some of this stuff, so it just depends on how much or how long you've smoked. Other common features: history of smoking in 80% of the patients, dyspnea, which means labored breathing, air hunger, coughing, and frequent pulmonary infections. Most patients develop hypoventilation accompanied by respiratory acidosis and hypoxemia. Emphysema is permanent enlargement of alveoli and destruction of alveolar walls, result in decreased lung elasticity with three consequences. Okay, so if you get permanent enlargement of the alveoli, you get these three consequences. You get the accessory muscles are necessary for breathing. So you'll get patients that come in with huge necks or muscles, usually scalenes, SEMs, anterior scalenes, you name it, traps, leading to exhaustion from using 10 to 15% more energy to breathe than normal. Trapped air causes hyperinflation, which flattens the diaphragm and causes expanded of a barrel chest, both of which reduces ventilation efficiency. Damaged pulmonary capillaries lead to enlarged right ventricle, so you're going to get an enlarged right ventricle. Okay. And then hereditary factors for disease include alpha-1 antitrypsin and deficiency. All right. Chronic bronchitis. Inhaled irritants cause chronic excessive mucus. Mucosa of lower respiratory passageways become inflamed and fibrosed, result in obstructed airways that impair lung ventilation and gas exchange. Symptoms include frequent pulmonary infections. Risk factors include smoking and environmental pollutants. COPD symptoms and treatment. Well, you've got strength of patient's innate respiratory drive is reason behind different symptoms seen in. There's two different kinds of people you're going to see. You're going to see pink puffers, or blue bloaters. So those are patients usually thin because they burn a large amount of energy breathing. Near normal blood acid are maintained, so skin color is normal. So those are your pink puffers. But then you got the blue bloaters. Patient usually stocky. Cyanosis is due to hypoxia, so skin color takes on this bluish hue. So how do you treat these pink puffers and blue bloaters? Bronchodilators, corticosteroids, oxygen, sometimes lung volume reduction, surgery. Oxygen must be administered carefully. Okay, so what do these guys look like? If you look at the blue bloater versus a pink puffer, again, blue bloaters, they have chronic bronchitis, chronic productive cough, purulent sputum, hemoptysis, mild dyspnea initially, cyanosis due to hypoxemia, peripheral edema, crackles, wheezes, prolonged expiration, very obese. Complications: secondary polycythemia vera due to hypoxemia, pulmonary hypertension due to reactive vasoconstriction from hypoxemia, cor pulmonale from chronic pulmonary hypertension. Lots of issues with these blue bloaters. Same thing with the pink puffers. Those are your emphysema. So you see those people that have smoked forever, and you're like, well, and they're just like this skinny, and you're just like, they have that look, and you know they smoked a lot. Dyspnea, minimal cough, increased minute ventilation, pink skin, pursed lip breathing, accessory muscle use, so their necks are huge, cachexia, hyperinflation, barrel chest, decreased breath sounds. Tachypnea means fast breathing. Pneumothorax due to bullae, and weight loss due to work or breathing. They're just working so hard. All right, just to look at this again, just to go on words, cachexia is just that skinny, withered, weak look. That's what cachexia means. Someone is cachexic. Bulle is blisters. Okay, so again, it's chronic bronchitis. And then you did take a test on this, and just to kind of make sure, I don't know if you guys know what cor pulmonale means. Cor pulmonale, that wasn't on the test, but cor pulmonale means issues with the right ventricle. So if you have issues with the right ventricle, you're going to get edema in your legs, okay, right, because it backs up. And if you have issues with your left ventricle, you're going to get issues, edema in the lungs, and that was on the test. So if you see that again, make sure. Okay, so if you have issues with your right ventricle, that's the fluid's going to back up in your legs, peripheral edema. If you have issues with your left ventricle, it's going to have issues in the lungs, and you're going to have edema in the lungs. So good to know there. Good test questions here. Okay, cachexics just means the skinny, weak look, and bulle are little blisters, fluid-filled blisters. Okay. All right, so pathogenesis of COPD, how does it happen? Well, you get tobacco smoke or air pollution goes down. Continual, you get irritation and inflammation in your lungs. The breakdown of elastin in connective tissue of the lungs. So, okay, so chronic bronchitis is excessive mucus production, chronic productive cough. Emphysema is destruction of the alveolar walls, loss of lung elasticity. So they both lead to airway obstruction, air trapping, dyspnea, which is difficulty breathing, frequent infections, leads to hypoventilation, hypoxia, and respiratory acidosis. So no good. Asthma, or in India they call it asthma. I always wondered, you go to India and they're like, oh yes, you have asthma. What is asthma? I'm like, you mean asthma? Yeah, you know how they like to pronounce everything. But sometimes classified as COPD, but episodes are acute, not chronic, with symptom-free periods, characterized by coughing, dyspnea, wheezing, and chest tightness. Active inflammation of airways precedes bronchospasms. Airway inflammation in the immune response caused by release of interleukins, production of IgE, and recruitment of inflammatory cells. So there's a lot of treatment for asthma. A lot of people suffer from asthma. Airways thicken with inflammatory exudate, magnify effect of bronchospasm. So usually bronchodilators, albuterol is but Xopenex is also, albuterol sometimes gives you the shakes too much, so they'll give you Xopenex, which is a little bit easier to tolerate. TB, it's caused by infectious disease, caused by bacterium, Mycobacterium tuberculosis to be specific. Symptoms include fever, night sweats, weight loss, racking cough, coughing up blood. Treatment used to be 9 months, but it's a 12-month course of antibiotics, specifically INH. Antibiotic resistant strains have been seen, including multi-drug resistant strains. So it depends on which country you get it from. Some of them are antibiotic resistant, so they'll have to try different courses of antibiotics that are a lot stronger. Now, if you get, let's say you're exposed to somebody that has tuberculosis, they have active TB, you might be exposed to it, but then your body, if it has a good enough immune system, it will trap that Mycobacterium tuberculosis in your lungs, cause this tight capsule around it, and that'll be the end of it. You'll still test positive for PPD, but usually you'll never break free and you'll never get active TB. You'll be labeled as latent TB. Okay. All right, so here's an X-ray of someone with latent versus active TB. So latent, you might have these little nodules here again, little tight little nodules. They'll never break free. But someone that has active TB, basically, it's invaded the entire lungs here. Okay. So there's a big difference between active TB. Now these people can infect normal people, but latent TB, you cannot give that to anybody. So again, latent versus active. So latent has no symptoms, does not feel sick, cannot spread TB. Usually has a skin test or blood test resulting that you have TB, but that's about it. Normal chest X-ray sometimes, or you might see a little bit of nodules here. Needs treatment for latent TB. Again, the CDC recommends 12 months of INH to prevent the TB disease, meaning it makes that capsule just tighter and tighter so it doesn't break free. Now, somebody that has active TB, well, they've got a bad cough that lasts 3 weeks or longer, pain in the chest, coughing up blood, weakness, fatigue, weight loss, no appetite, chills, fever, sweating at night, usually feel sick, may spread TB, depending on how active it is. Usually has a skin test, a blood test indicating TB, may have abnormal chest x-rays, positive sputum, and needs treatment to treat TB. Okay, so big difference between latent and active. Lung cancer, leading cause of cancer deaths in North America. 90% of all cases are a result of smoking. Lung cancer, the three most common types are adenocarcinoma, roughly 40%, squamous cell carcinoma, roughly 20%, and small cell carcinoma, roughly 15%. So adenocarcinoma originates in the peripheral lung areas, develops from bronchial glands and alveolar cells. Squamous cell carcinoma arises in the bronchial epithelium. And the small cell carcinoma contains lymphocyte-like cells that originate in primary bronchi and subsequently metastasize. Treatment for lung cancer, early detection is the key to survival. If metastasis has not occurred, surgery to remove diseased lung tissue. If metastasis has occurred, radiation and chemotherapy. Several new therapies are on the horizon, immunotherapy, but again, it's just dependent on the individual. Sleep apnea, Dominic did a good job of that, so I'm not going to go into details, but sleep apnea, common disorder characterized by temporary cessation of breathing during sleep. Person usually not aware of the problem, leads to excessive daytime sleepiness due to waking up several times each night, can be up to 30 per hour. Obstructive sleep apnea, most common type caused by collapse of upper airway, pharynx muscles relax during sleep, and sag, causing obstruction. Central sleep apnea, caused by reduced drive from respiratory centers of the brainstem, consequence of disrupted sleep, susceptibility to accidents, increasing chronic illness, hypertension, heart disease, stroke, and diabetes. And then pressure from CPAP holds airway open, preventing the collapse, and that's the treatments that you saw. All right, those that smoke marijuana, if you believe that that's good for you. All right, how does marijuana affect the brain? Well, THC, key ingredient in marijuana, attaches to the cannabinoid receptors. Remember, you had those cannabinoid receptors when we talked about neurotransmitters throughout the body. Several areas of the brain have high densities of these receptors, which helps explain the different effects of the drug, and it depends on the individual. So how the receptors work. Nerve cells communicate by passing chemical messages across contact points called synapses, right? Talked about those. The most active ingredient in marijuana, THC, attaches to the cannabinoid receptors and modifies the nerve action, so that's how it works. Some areas of high concentration, so where do you have these cannabinoid receptors? Now again, depending on the individual, where you have these high receptors are the kind of reactions that you're going to get. So that's why everybody gets a different reaction to this. So let's say you have a high amount of receptors in your cerebral cortex, which plays a role in memory, thinking, perceptual awareness, and consciousness. Well, then the effects of marijuana will be altered consciousness, perceptual distortions, memory impairments, occasional delusions, and hallucinations. Well, let's say you have a high amount of cannabinoid receptors in the hypothalamus, which is what majority of people have, governs metabolic processes such as appetite. You're just going to have increased appetite. That's what the majority of that those receptors do. So that's now some of you have a high bunch of receptors in the brainstem, controls many basic functions, including arousal, the vomiting reflex, blood pressure, and heart rate. So you're going to get nausea relief, rapid heart rate, reduced blood pressure, drowsiness. So those that say, oh, I smoke marijuana to help with my chemo and gives me nausea relief. Well, you have to have a high amount of chemoreceptors in your brainstem to get that relief. Now, let's say if you want pain reduction, again, you have to have a high amount of receptors in your brainstem to get that pain reduction and nausea relief. So if you don't have that, that's why when some people smoke marijuana, they say, oh yeah, it's really helped me, helps with my pain, helps with my nausea. And some people take it and they're like, well, all it did was made me hungry. And someone say, well, all I did was see hallucinations. Well, that's the reason why, right? Hippocampus is the key to memory, storage, and recall. Well, some of you will just forget everything if you smoke marijuana. And again, cerebellum governs coordination and muscle control. So you might have reduced spasticity, but you'll have impaired coordination. So somebody that has spasticity, someone that with an upper motor neuron lesion, well, they might smoke marijuana and they get reduced spasticity. But if you don't have that, then you might get impaired coordination, fall down the stairs. Amygdala, that plays a role in your emotions. So if you have a high amount of cannabinoid receptors in your amygdala, guess what? You're going to get anxiety, panic, or you might get some reduced anxiety and blocking of traumatic memories in other cases. So it just depends. Depends on. So when one person says, yeah, you should smoke marijuana, you know what? If it works for you, go for it. Just don't tell me what to do. I'll make my own decision. So that's what I just don't like it when other people force things on other people. If you like it, if you want to drink, if you want to smoke, do it. It's fine. But don't make other people do it just because it helps you. Just do your own thing and stop forcing other things. Okay? So estimated percentage of people in a national survey who used substances at least once and became dependent: tobacco, heroin, cocaine, alcohol, stimulants, and then marijuana is about 9%. So, those that love marijuana, they'll say, oh yeah, it's less addictive than alcohol, less addictive than tobacco, heroin. Yeah, it is. But again, some of the side effects that can occur just depends on the individual. So the choice is yours. All right.